For being here. Like Katie said, I have a data-driven chiropractic office just down the road. I'm not going to be talking about that at all today. Today, what I'm going to be talking about is discomfort, talking about pain, and talking about what we can do to decrease our pain and what pain really is. Because there's a lot of misconceptions around pain. And what the research shows is just by learning about pain, just by understanding how pain works and how the body processes pain, we recover from pain faster, and we're able to do more of the activities that we want to do throughout life. So that's what we're going to be talking about today. So again, why a talk on pain? And if I yell, and you guys are like, you're yelling, just tell me to bring it down, because sometimes I just get loud and I yell. And then also, if you have any questions, just stop me and let me know. I'm going to stop twice and ask if there's any questions. But again, my goal for you all is to leave here and be like, oh, I'm less scared about pain and I know what to do now. That's my goal. So why talk on pain? Well, we all have a life expectancy. And in the United States, the life expectancy is 73.2 years. Now, we're in Upper Arlington, so our life expectancy, just from a demographic standpoint, is going to be about 5 to 10 years longer than the American average. We won't go into that, but that's what we know, okay? So our life expectancy, our lifespan is 73.2 years. However, on average, one thing we don't talk about is our health span. Our health span is how long we are alive and we're able to do the activities and do the things that we want to do. And on average, that health span is 64 years. So we have about a decade or more of life at the end where we're in pain and we're not being able to do the things that we want to do. And there's cardiovascular disease, there's all these other different drivers for that decrease in function. But one of the main reasons for that decrease in function is because of pain, because we don't know about pain and we let pain hold us back. So pain holds us back from the lives that we want to live. And by learning about pain, by learning about what we can do with our pain and what we can do to get through pain, we can extend our health span so that instead of having a nice, healthy life and then a slow 10-year degrade, you can have a nice, healthy life and then just die. And not have to worry about all that pain and discomfort and suffering. You just stay active, you don't worry about pain, and that's the end. Instead of that slow degrade. Okay? So understanding pain allows us to take an active role in our pain experience. There's a lot of misnomers, there's a lot of myths about pain, and we're going to cover all of that today. What's really cool about the research on pain neuroscience education is that when you combine the education about pain with physical therapy, with exercise, with chiropractic, even with orthopedic surgery, people get better than if they just have the intervention, and people get better just with the education. So in theory, you all being here are going to process pain better afterwards, you're going to understand it better, and throughout life, hopefully if I do my job today, you're going to have better experiences with pain moving forward. Like I said, it's been shown to be effective in reducing pain and improving function on its own. So there's some facts that we need to know about pain. Pain is a normal human experience. Pain exists to keep us safe. Without our ability to experience pain, we wouldn't survive. So I want you all to think about the little toddler in a room when the caregiver is cooking. Caregiver, mom, dad, whoever, leaves the room, stovetop's on, they're a toddler, they're checking things out. They decide they want to put their hand on the stove. Because why not? Mom's over there. So they walk over, put their hand on the stove, they jerk away really quick. Why do they do that? Well, pain sends a signal to the brain. This is harmful. This is going to cause damage. We need to get away. And again, that's an evolutionary just fact of the matter. We need pain to keep us alive. So that keeps us in that moment, that keeps us alive to stop any further damage. That's good. Living in pain, however, is not okay. We should not have to live our entire life in pain. or have pain over 6 months, or have pain that keeps coming back over and over and over again. And I'm not talking about, oh, my knee is a little sore. I'm talking about that pain where you're like, this is negatively affecting my function and what I'm able to do in my life. The other thing about pain is that what we rarely talk about is pain is multidimensional. Pain is not just signal, brain, I feel this level of pain for this level of injury, and we're all good. My best friend and I played football in high school. And he played left tackle. He was blocking a guy. A guy came in and hit his knee. He played the rest of the game. Then afterwards, the next day, felt his knee was a little bit sore. Went to the doctor. They did a couple of orthopedic tests. They said, I think you have a torn ACL. He hardly had any pain at all during the game, but he ended up tearing 4 ligaments in his knee. So a lot of damage, but there was adrenaline. He was in front of a crowd. He didn't feel any pain. So pain can be modulated and changed, and there's a lot of different factors that play a role in that. For instance, our past experiences with pain. If we had a caregiver that we were walking and were little and we scratched our knee, and the rest of the day they're, are you okay? Are you okay? Are you going to be fine? Versus a caregiver that said, oh, get up, you're fine. Both of those two individuals are going to process pain differently, and guess what? We don't get to know which one is going to process it better, because there's so many other factors that play a role in that processing of pain. Our worry, our fear around pain, if we're an individual that we feel pain and we're like, oh my gosh, what is this? And we really start to ruminate on it, then our brain gets more focused on that, and we get hypersensitive to that pain. Research has shown by just decreasing our sleep, we feel more pain. If we sleep less, if our body's not able to fully recover, we're more hypersensitive, so that changes our pain. How well we cope with pain, our activity or lack of activity, the actual damage done can play a role, but it's not the end-all be-all. And that's one thing, as we get into some of the myths, I'm going to really degrade imaging, but imaging does play a role. So that sensory input from the injury can matter. It plays a role. It's just one piece of the puzzle. Again, our central processing, our brain, how it processes pain is going to be different. Someone that was in a traumatic car accident at 4 years old and was in a body cast and had to recover that throughout their developmental process is going to process some pain differently than someone that never had an experience with that. So we're just going to process pain differently, and we all process pain differently, and there's a lot involved in it. Now let's talk about some of the myths and the legends of pain. Okay. The reason I wanted to do this talk so much was first because the research says that it's helpful, but second is because I am in a profession that likes to do a thing called scare care. There's a lot of healthcare professions that do this. There's therapists, not all of them, but some, and it's very common. Physical therapists, chiropractors, orthopedic surgeon, where they say something along the lines of, they see your x-ray and they say, you got the spine of a 90-year-old. This is the worst spine I've ever seen in my life, and if you don't do something about this, it's going to get worse. And what we know from the research is that if someone has an interaction with the doctor that says that, their recovery is vastly diminished. Just because that idea is put into their brain of, I'm out of luck. If I have the spine of a 90-year-old, I can't reverse that. I can't change that. If that's really the reason I have pain, well, this is my bed that I've got to sleep in. This is just how it's going to be. So let's dive into some of those myths and some of the facts. Again, this is why you're in pain. Oftentimes we'll have an injury, and the body's complicated. It's complicated. There's a lot of things going on. For instance, if you all just do me a favor, close your eyes. Okay? I want you to touch your nose with your finger. Okay. How'd you do that? You can open your eyes. You just did it. You didn't even have to think about anything. You just were able to do it. Okay? Well, you have little sensors that are throughout our entire body. They're constantly communicating with the brain and giving us feedback about our awareness and where we are at in space. So say someone's walking and they roll their ankle, it hurts. Lean over to the other side. They walk on the other side a little bit. Hopefully everything heals. The body has an inflammatory response. It clears out all those tissues. It heals the tissues. We're able to walk and we're able to be fine. Okay? However, those sensors can be altered. And those sensors heal and are normal. And like we said, with the pieces of the puzzle, there can be different factors that change that healing process. But I want you to keep those sensors in your mind. The brain is constantly bringing in information and then adjusting accordingly. Okay? So, say someone has lower back pain. They go to their doctor. The doctor says, hey, we need an MRI, we need a CT, we need whatever imaging that we need. They do it and they say, oh my gosh, you have disc degeneration. This is bad. You shouldn't have disc degeneration like that. Or they say, oh, you've got a disc bulge. You've got a bulging disc in your lower back. This is causing your pain. When it could be, but there's a really high percentage chance that it's actually not. Because a study looked at over 1,200 individuals from the ages of 20 to 80. These were individuals with no pain, no symptoms. 37% of 20-year-olds have disc degeneration. 24%, their discs are shrunk. So someone could pull it up on an MRI or an X-ray and say, oh, that's your issue, that's why you have pain. Disc bulge, 30%, disc protrusion. You have all these scary imaging findings that the majority of us are walking around with no pain. There was another study that I didn't pull up, but they looked at disc bulges of people while they were laying down in an MRI, and then while they were standing. Half of the disc bulges went away in the standing MRI. Because it's just one piece of the puzzle, of this complex puzzle of how our body moves and interprets pain. Again, pain is multidimensional. There's a lot going on.
Do you believe that 37% of 20-year-olds have disc degeneration?
Yeah.
You do?
Yeah. So when I was in chiropractic college, I'm healthy. I try to be a healthy person. I thought I had a really great spine. I have 2 compression fractures in my spine. I've got one in my neck and one in my back. I have what they call an anteriolisthesis, which is where your vertebrae slides forward on the vertebrae below. So you have the sacrum, which is the tailbone, and my vertebrae slid forward. Now it's a very early stage. I don't know where it is now, because that was about a decade ago. But I have that sliding forward, and I had degeneration in my neck as well. Now, if there is a perfect world where we weren't put in a desk at 8 years old and told to not move for 8 hours a day, and we were active and we were moving and we weren't stressed and we were eating the right things, do I think these numbers would be different? Absolutely. However, they exist and they don't always lead to pain as well. And so that's really the nuances of it is, and I was talking to a chiropractor friend and he's like, I disagree wholeheartedly with what you're saying, because he's like, this stuff really matters. And I'm like, absolutely. From a biomechanics standpoint, it matters. But from a pain standpoint, it doesn't. And that's really the key. But this doesn't just have to do with the spine, because it's the same with the shoulder, same with the knee, it's the same with almost every other body part. So in this study, they looked at a group of individuals that came in for shoulder pain in one shoulder, and they said, you know what, they have one shoulder in pain and they have one shoulder that's not in pain. We're going to image both of them to see what the findings are. Okay? So what they found in the painful shoulder, rotator cuff tendinopathy. So tendinopathy is just inflammation of the tendon, and they can see that in an MRI. They found that 74% of the people with the painful shoulder, and the pain for shoulder, have that tendinopathy. Guess what? The pain-free shoulder, 73% of the time it was also there. Same thing with a partial thickness tear. Even though there was a partial tear in those shoulder muscles, there was still no pain, even though it was seen 22% of the time. And we can go down. Now, full thickness tear, when there's a traumatic injury, trauma is a lot different than oh, this is bugging me every once in a while, or pain that continues to come up. a trauma of someone in a car accident, that changes this dynamic, and it changes the dynamic of the last one as well. But these are people that, you know, a 40-year-old dude that's playing golf and his shoulder keeps bothering him, and he goes into his doctor and he says, did anything traumatic happen? He's like, no, okay, we're gonna do an imaging of your shoulder. And so that's what this is really looking at. And when we go through this list, again, all the things that they look at to determine whether we should do surgery, whether there's an actual issue, it shows up both in the pain-free shoulder and the painful shoulder. A lot of times we're told hurt equals harm, that the level of pain that you're feeling is directly correlated to your imaging and what is going on, and it's just not true. It's just not accurate. Let's go to the knees, okay? I hear so many people say, oh, running's bad for your knees, squatting's bad for your knees, all these different things are bad for your knees, or, oh, this degeneration in your knee, this is where your pain's at. Running is good for your knees, squatting is good for your knees, movement is what the body thrives on and needs. Our body is a feedback loop, just like we were talking about those sensors. When we don't move, so they did a study where they put someone's leg in a cast, didn't allow them to move their leg for a week, and a 30% decrease in their muscles just from 1 week of being immobile. So our body is constantly checking in with itself and saying, where do we need to put resources, where do we need to supply resources, and then it makes that tissue stronger, it makes that tissue more robust. So when we decrease our activity a lot, that tissue gets weaker and we're more likely to have an injury, and we're more likely to develop pain. If we have time to talk about muscle fibers. But they looked at the study looked at knees, and they found that osteoarthritis, so the scary arthritis term that we all talk about, features on MRI in otherwise healthy people, asymptomatic, so no pain, no trauma, is up to 43% in age of individuals that are 40 years or older. This is one of the things that's really hard to work with patients on in my practice when they say, hey, I saw my doctor, my knee has degeneration, they really want me to go forward with surgery. And then some of my patients I see through, every 6 weeks, every 8 weeks, they've seen me, we've taken care of their initial thing, now they're just checking in, and they come in 6 weeks later, well, what's your next step for the doctor? Well, I don't have an appointment for another 3 months, but my knee pain's gone. Well, the degeneration just didn't go away overnight. There's other factors playing a role. And that's another key takeaway, is that there's other factors playing a role, and we just point to the imaging, but we have arthritis, we have movement, we have that ability to heal. There was one study that looked at a group of people that went forward with knee surgery for just the arthroscopy. So if any of you follow sports, a lot of NBA players will have there's just a meniscus issue, we're just going to come in and scrape that off. Well, the research shows that there's really no difference in someone that has that surgery or someone that doesn't when they go through a physical therapy program or an activity-based program on fixing that issue. So again, key takeaway, if someone tells you you're broken, it's the worst spine I've ever seen, this imaging is why your issue is, question them, ask them questions, or run away. Those are your only two options you get, okay? So, dangers of pain myths. Well, the research shows us if someone is told they have a horrible issue, they do worse. We don't have time to talk about mental health today, but that's a component that, think about it as it relates to this. When you tell someone you're broken, you're doing worse, this is going to go worse, they do worse. That just doesn't have to do with pain, that has to do with pretty much everything. Okay, so one of the dangers of pain is worse outcomes. Our body thrives on activity and movement, and it helps the healing process. When someone is told they're broken, this is wrong with you, this is your pain, we decrease our activity level, which actually makes us develop more pain and more dysfunction. So we have further loss of movement function. Again, it's often used to scare or intimidate individuals in pain to push them towards care. And this happens in every profession. It's not everybody, but it is a sad reality of orthopedic surgery, of physical therapy, of chiropractic, of any modality that's working to improve someone's health and function, and it's something just to be aware of. And again, it leads to catastrophizing, it leads to fear avoidance, it leads us to quit doing the things that we want to do. And if we think about that health span versus lifespan, we want to keep that health span long. So we want to avoid people that make stuff up. All right, so let's talk about the neuroscience of pain. Okay, so our brain is here, and it is processing so much information. Because you moved your finger to touch your nose, well, if you were standing and you did that, your left erector spinae is going to say, oh, we had a different change in our orientation. It's going to fire a little bit more. If your eyes are closed, your vestibular system is going to fire so that your body knows where your head's at. So all these different things are happening, and your brain is processing all of that. In our body, we have 400 individual nerves, and if you put all those nerves together and stretch them out, they travel more than 45 miles. So we're pretty complex, and we're pretty cool. Our brain and our spinal cord is part of our central nervous system. And it can be broken down into pretty much two parts. Our parasympathetic, which is that rest and digest and recover. It's hopefully where all of us are today, except me, because I'm up here speaking, of just nice, calm, relaxed. And then we have that sympathetic. We have the 2-year-old touching the stove top. We have my buddy that got his knee torn. That fight or flight response, that adrenaline, it's really good short term. When it starts occurring long term though, that's when we get the issues. That's when we start to develop that chronic pain. So again, sensors, parasympathetic versus sympathetic, okay? I like to think of the central nervous system as a very complex highway system, and the brain as monitoring that highway system. And if there's a wreck, dispatch calls the brain and says, we need to clean this up as quickly as possible. And the brain does all that stuff. That's that acute inflammatory response when there's an injury. However, imagine dispatch thinks that a piece of trash on the road is just as important as an 8-car pileup. And sometimes our brain does that based on those other puzzle pieces of the multidimensional aspects of pain. Pain is an alarm. Again, it occurs so that we can remove the real or anticipated threat of the tissue. And there's different things that are going to make us more sensitive or less sensitive. It's an alarm though. So when you feel pain, and you're like, this is it, I don't know if I'm ever going to be able to move my knee again. Remember, it doesn't equal harm, and it's just an alarm. It's happening for a quick reason, but it doesn't. Sometimes our alarms go off even though there's not a burglar in the house. And so that's what pain is. As we went over, there's multiple factors that influence the sensitivity of the alarm. Our hydration, we're not drinking enough water. Our body's 70% water. So if we're dehydrated, those little sensors, they're not able to act as effectively. Our brain is 70% water. If it's not filled with water, if it's not hydrated, it's not able to communicate as well. It's not able to process information as quickly or as accurately. Like I said, our past experiences, our beliefs around pain, if we're a very angry person and we're right on that edge of fight or flight all the time, just ready to just jump off the handle at someone, those people don't respond to pain as well as someone that's calm and relaxed. Just because their body's already close, it's already on the edge of that alarm going on. The pain-sleep relationship, I'm trying not to read all of them, but the pain-sleep relationship is a bidirectional one. Pain can disrupt sleep, and the shorter disturbed sleep in turn lowers pain thresholds and increases spontaneous pain. This is one of the reasons with many of my patients, I have them, or I recommend they do non-sleep deep relaxation before bed, which is just like a 10-minute guided meditation that helps bring down that fight or flight and bring up that rest or digest. A lot of them struggle with falling asleep because they're in pain, they aren't able to stay asleep, and then it just becomes a cycle of more pain and more pain. So there's a lot of low-hanging fruits that we can affect when it comes to pain to start feeling, functioning, and healing better. Again, Hurt does not equal harm. Pain is normal. It can be weird though. Pain is not an indication of tissue damage. It should not hold us back from the things that we want to do, obviously to a point. If you're in excruciating pain and you want to cry, you probably shouldn't go snowboarding. So use some common sense with this, but at the same time, if you're walking and you can walk 200 yards without pain, but 400 yards causes pain, well, maybe walk 300, as long as that pain goes away afterwards. So it really is about checking in with the body and finding those limits. Despite tissue healing, even though the body can heal, the alarm protection can persist past healing. And that's something to remember. That alarm system can still be going off even though there's not an actual issue. Pain is normal, living in pain isn't. Lastly, before we go into the next, we're halfway through. Central sensitization is when the central nervous system becomes hyper-aware. When our pain threshold drops and we feel pain when we shouldn't feel pain. Individuals with chronic fatigue syndrome, fibromyalgia, chronic low back pain, a lot of them have central sensitization, where essentially the brain is just it's hyperactive and it needs to be calmed down. It thinks things are pain when there isn't. So that alarm goes off when it shouldn't be going off. All right, so far, do we have any questions before we get into the fun stuff?
So, yeah, beyond the meditation, how do you suggest people manage their sleep?
So there's meditation. There's, which I'm just starting to get into this, there's one thing that's called sleep deprivation. And essentially what you do is you go to bed at 12 and you get up at 5. And you force yourself to stay up, and you don't take any naps during the day, and you force yourself to get up at the next time. And that's not like the best way to do it, but that's one way, because it makes your body realize this is the only time I can sleep, and it almost forces it into sleep. Reading before bed, things that are going to calm your brain down and get your focus off of sleep are some of the most beneficial things. So reading, crocheting, playing the piano, things that basically are to distract you and let your body calm down. I like reading textbooks because that just always puts me to sleep, and I just instantly go to sleep. So I'm like, oh, there we go. But the hard thing with sleep is that we know meditation can help. We know non-sleep deep relaxation can help. We know reading can help, but it's so individualized. And again, just like pain, there's multiple dimensions to it as well. It's really a spectrum. I think you're on my newsletter list. I've written a lot about sleep and how to improve sleep, so I can share more articles with you on that. Yeah.
I think that's the
Yeah. Mm-hmm. Yeah. And so that's when, if someone's waking up uncomfortable, that's when I do talk a little bit about sleeping position, and just orienting your body in a way that's not as painful. And that's what it's about. It's finding positions where you can fall asleep comfortably, and wake up in the morning refreshed and not in pain. Sometimes that's putting a leg between the pillow. Sometimes that's making sure your pillow's not pushing your way up or dropping way low. For a lot of people with neck pain, if they quit sleeping on their stomach like this, that can help. So there's little intricacies dependent on the individual.
Yes, sir.
So you can train your brain to be more sensitive to pain than it really should be?
So, in theory, we could, but what happens is our body just becomes that. Sometimes the stress and the conditions outside of the painful stimulus are overwhelming the brain, then the brain gets in a hypersensitive state, and then we feel pain when it's not necessarily at the level where it should be. Does that make sense? All right. We got a little bit more to cover. Okay, so what do we do with pain? So like I said, all that degeneration in my spine that I had. When I was in chiropractic college, they decided, we had a class where everyone got x-rays, just to look at our spine and learn. Spines are irradiated, tons of people to pass a class. What happens is we have a normal threshold for pain. Okay? That's our firing level, that's our alarm clock. When our body is in pain, what happens is tissues get extra sensitive and our room for activity decreases. For me, I got that x-ray and I had a professor tell me I should quit doing squats and I should quit lunging and I should quit doing anything that loads my spine. I was not in pain before this, but after that, every time I got under a barbell, anytime I did a lift, in the back of my mind was, my spine is structurally unstable, I'm going to hurt myself. Eventually, probably from getting adjusted by a bunch of people that didn't know how to adjust, I did develop lower back pain. So all of a sudden, my room for activities decreased, where I couldn't squat a certain way, or I couldn't do certain things. So what do we do with pain? Well, what I had to do is, instead of going from back squat, which I knew would line up my back, I had to change to front squat. For some people that get pain when they're sprinting at 100%, we need to back them off and say, hey, let's sprint at 80% and then slowly increase that load to get the body back to where this room for activities gets larger, because essentially we can desensitize that tissue if there's not actual damage there. And like I mentioned earlier, a lot of the time it's a processing problem and not an actual structural problem. And that's the load. That's the amount of movement and activity that we're doing. A lot of the injuries that we see in college athletics and people that are active is they are following a training protocol or not training a protocol, where they are going from running 5 miles a week to 10 miles a week to 20 miles a week. The body needs times to adapt. It needs time to lay down more tissue. It needs time to get stronger and more resilient. So if we increase that load too quick, then our body can't adapt to it. And a lot of the times that's why the injuries occur, is because we're not managing our load properly. And just by properly managing our load and activities, we can really improve our chances of not developing pain and not getting injured. Okay. So, what do we do with pain? First of all, don't ignore it. Don't hyperfixate on it. But if you're having pain and it's continuing to come back, then you want to learn about your body. One of the things I say to so many of my patients is, just get on the floor and move. Just get on the floor and move and learn what feels good, what doesn't feel good, how well your body moves, because motor control and our brain processing movement, when we move, it sends a signal to our brain that, hey, everything's working. And when we don't move, our brain gets a signal of, okay, what's going on there? And then it gets more hypersensitive again. So don't ignore it, learn about it. You're here, hopefully you've gotten a little bit so far. And then address it. You can address it by movement. You can address it by working to get that parasympathetic activity, that rest and digest, more activated. Aerobic exercise alone, just starting to increase your daily walking, can decrease our pain levels. As we mentioned, relaxation, being told when you're in pain, go relax, usually doesn't work, but when we address it ourselves and work on relaxing, it can help. Meditation. There was a study that had a group of individuals in chronic pain do 20 minutes of deep breathing for 12 weeks, and they had a 50% reduction in pain, just from 12 weeks of 20-minute breathing. But again, if we think about that hypersensitivity of the brain and the parasympathetic activity and the sympathetic activity and that fight or flight, that deep breathing gets the body to say, oh, we're calm, we're safe, and it decreases that sensitivity. Graded exposure is kind of what I was talking about with the squat. Changing up the position from a front squat or from a back squat to a front squat, or changing your strength from 100% to 80%, or instead of getting on the floor and playing with your kid for 3 hours, maybe we back it off to 2 hours and we have someone else step in for the other 2. Just doing those little things of changing our habits. Manual therapy, chiropractic, physical therapy, those things can help. Again, that's a whole nother topic that we could dive into. Modalities, acupuncture, massage, those are all things that can help. And then goal setting has also been shown that if someone is in pain and they have goals that they want to reach, just that goal setting and starting to take actions to reach that, they respond better to pain and they get better. Let's talk a little bit about the importance of movement. Okay? Say I am curling a 30-pound dumbbell. My body, because I've done this many times, has that capability. Now all of a sudden, if I decide to, someone's running by me and I try to grab them because they stole my wife's purse, and they're 250 pounds and they're a lot stronger and bigger than me, that's a lot different than a 30-pound dumbbell. Probably going to try and grab them and I might rupture my tendon. And what that really is that our body, every ligament, every tendon, every muscle, even our heart, has a functional capacity. And the more we utilize it, the more we train it in a smart, specific way, the more demand it can take. However, if we're untrained, if we're deconditioned, if we haven't done anything, and then there's a high external demand, then our risk of injury really is high. So again, when you think about the college athletes, when you think about someone training for something, when they ramp up too quickly, they're more likely to get injured. So the importance of movement is when you're in pain, you want to avoid activities that you know are going to constantly cause pain. But that doesn't mean stop all activities. It means find activities that you can do that don't cause pain, because that's going to help you heal faster. Slowly increase the movements. So say this causes pain, but this doesn't, this doesn't, this doesn't, this doesn't. Well, every once in a while, go forward and say, okay, is this getting better or not? Is this movement here feeling more awkward or less awkward? And all the other movements outside of this area are going to help you build capacity eventually in this area as well. And then again, the strengthening the tissue. We're all going to get injured. We're all going to get in pain. We can't make a body that doesn't get injured and degrade and stuff happen. But the stronger a tissue is, the more likely it is to be able to be more resilient, have less pain, and less discomfort. So as we talked about, there's some low-hanging fruits of decreasing pain. You all have the sheets: the deep breathing, the meditation, aerobic exercise, and movement. Those are 4 things that we all have the capability to do. There's tons of resources online. I have tons of resources on my website about how to incorporate these different activities into your life. Because again, if we can just decrease that hypersensitivity, we're all already taking a step to feeling moving and feeling better. So, all right, you're in pain. You tried all this stuff on your own. Now, when do you actually get help? When do you want to get help? Well, when pain's holding you back from the things that you want to do on your own. If you're a golfer and you want to be able to play 18 holes of golf once a week, twice a week, or once a month, and your pain's holding you back from doing that, and you're not able to handle it on your own, that's when you go see someone. If it's stopping you from recovering as fast as you want to, that's when you go get it. That's when you go see someone. And if you're not feeling sensation, if you're getting numbness or tingling, go see someone. If you're having constant pain and resting your shoulder, resting your back, resting your leg doesn't give you any relief, you need to go see someone. If you have weight loss without intention, that's the sign of a bigger issue. You need to go see someone. Same thing. If there's a violent trauma, you're in a car accident, you're anything that's violent, numbness and tingling, if you're starting to feel numbness and tingling, if you have leg pain with back pain, and if you have changes in strength. Specifically if it's a rapid change in strength. Those are times where it's like, no, you don't handle that on your own. Go see someone. It might be completely unrelated to your imaging. It might be something that they can help you through without anything drastic. But these are some of the signs of, hey, yeah, we need to do a little bit more work. All right, so again, pain is a normal human experience, and without the ability to experience pain, we wouldn't survive. Pain can be extremely useful. Living in pain, however, is not normal. Pain is multidimensional. Remember this part. Please bring this home with you. There's a lot of different aspects that play a role when it comes to pain. Also, we all have the inherent ability to reduce our pain levels, and it takes time and effort. It's one of the hardest things about health. It's one of the hardest things about being human. It takes time and effort. It just does. Nothing's going to change if we change nothing. And so that's always a hard realization. All right. Any questions? I'm an open book. I'll answer anything if I have an answer.
So I had lower back pain for a while. So when you're talking about degenerative disc, so when I was in my 20s, I was sitting cross-legged, I sneezed, felt a pop, and then the next day I couldn't walk. Like every time I would step, it was like a knife like being shoved in my back. So I ended up going to see a chiropractor and had everything adjusted over. But I had the MRI and they said, oh, degenerative disc, oh, you know. But then they were like, but some people have degenerative disc, they don't have any pain. And I'm like, so is that what it is? They're like, we don't know. So but running helped.
Yeah.
But the thing I was curious about is I noticed that, what does a TENS machine do? Like, because I know they had me do that on my back and it helped, but I don't know what that is or why that helped or.
So it's modulating the pain receptors and the fibers that are communicating that pain signal.
Okay.
And so whether it's a TENS unit, there's different types of TENS units, there's different types of modalities like that.
Yeah.
But it's working on the sensors and trying to deaden that area.
It was interesting to me because massage made it worse, physical therapy made it worse. That seemed to work, but it was like I had to relax. Like I had to relax in order for it to not hurt anymore.
Yeah.
So yeah, I was just curious because I was like, I like it, but I just don't know what it does.
Yeah. It modulates those sensors and that pain signal. Some of them do it by fatiguing the heck out of the muscle. Some of it do it by causing the muscle to slightly spasm.
Yeah.
Some of them.
It was like more of a spasmy.
Yeah.
Yeah.
So it's working. Sometimes when we have pain, that muscle is overactive.
Okay.
And so essentially what a TENS unit can do is it can just let that muscle know like, hey, you're fine, you can move, you have function, just calm down. Yeah. Yes?
I have a question. You had mentioned overuse injuries on there as well. And so I was a D1 track runner in college and I've heard that so many times with like feet injuries and knee injuries because I do have sesamoiditis in my feet and like my knees, so I don't really run. I do like power walk or go to Orange Theory and like do that. But like with an overuse injury when they're like surgery is not an option for your feet because we don't know if it's gonna make it any better, but it still hurts. What do you do? Like you just be in pain? Like this is where I've like kind of hit a wall because I've been to so many people and they're like that are overuse injuries from repetitive running there, but you won't benefit from surgery. So you're kind of like, do I just deal with it?
And that's so wonderful question.
Okay.
Yeah, wonderful question. So there's a lot of questions I would want to ask you, but I'm going to just take your example and go a different way with it.
Yeah.
Since I'm not going to ask your questions in front of everybody. Because if someone comes to me and they're in chronic pain, and I need to know if walking is causing them pain or if running is causing them pain, what can they do without pain? Or what are they able to do that doesn't cause them pain in that area? And then what you can do is you can start to slowly load that body more and help that desensitization process and go really, you gotta go slow. And in the beginning, we look for more good days than bad days. And that's really my point to drive home is, you're gonna have bad days, we just wanna start stringing more good days together. So starting to improve the movement and function of that area and properly loading that tissue over time in a structured, thought out manner can help. Again, doing the deep breathing, because a lot of times what will happen is with a chronic injury, your brain already has a spot. It's ready to rock and roll. That alarm system is fine-tuned to that injury. So as soon as we injure it, it lights up and it's like, hey, I'm gonna stick around and let you know it's there for a while. That's my lower back. I lift weights, I run, I do a lot of activity, but I know my body well enough and in pain enough that I know that if I do 2-3 mile runs and squat in the same weight I'm going to be in pain and my next week of work is not going to be fun. But if I run 3 miles on Monday and I squat heavy on Thursday, I'm good to go. But if I run 3 miles on Monday and I do no lower back activity, then I'm going to be in pain again because my body needs that movement. So there's a lot of nuances to it, but in general, I would say we got to work on the load capacity of the tissue. We got to work on getting the body to relax when it's starting to feel pain, and we've got to get people to quit telling people that no, this is just how it's going to be forever, because it's real. Like, it can be, but rarely is it the case. I've yet to work with someone that will do the work who hasn't gotten better. So yeah, it's managing the load.
And that's what I've kind of been trying to do. Like,
Yeah.
that you can only go so far else. When you had mindset shift, when you're in a competitive sport, you're like, I know only 2 speeds, 0 or 100, and so I think that was a while that it took me to kind of say, like, I'm not competing for this. You're just trying to maintain like consistency in working out. So but I've been told that a lot of like, you're just gonna have to deal with it. So I was like, it can't be the answer, right?
It's not the answer.
Okay.
And but that's one of the hardest things is we tell people that the degeneration is causing them pain. We tell them at the same time, while they're an athlete, work through the pain. And so, like, there's all these weird different mixed signals that we get growing up and learning about our bodies and pain, where we're just kind of put in a situation where we're 35 or 85 and we're like, I have no idea what's factually true or untrue or what to do about the situation. So yeah, it's gonna be, I mean, there's small biomechanical factors, but primarily managing load. If you want to handle it on your own, it's gonna be managing load. I would even get a little notebook and take notes just to kind of learn more about what you can and can't do, what helps, what doesn't help. It's a nuanced approach, and that's why I think a lot of us don't talk about pain and talk about these complexities, because it takes a conversation. It takes more than 2 minutes, and it takes really getting to understand the individual, their relationship with pain, their relationship with working out, like all of that plays a role. Did that answer your question?
It did.
Okay.